This lecture is being brought to you in part by the generous gifts of these sponsors.
All right, thank you for that kind introduction. It's great to be back and see so many people interested in thyroid. So what I want to do tonight is kind of think through the patient journey with thyroid nodules and thyroid cancer and kind of have a logical progression of how we travel through the workup. And most patients end up not going the whole way to having advanced cancer, but we want to talk about that as well. So just as we start off, how many people know someone with a thyroid problem? Almost, and it could be yourself, of course, as well. Good. How about thyroid nodules? Exactly. How about thyroid cancer? Yeah, so that's all right. And how many people know where the thyroid gland is? Hopefully everybody. It's funny, you see even endocrine websites, you'll say, oh, you're a thyroid specialist, and the person is examining the salivary glands. And you'll see that, associations use that. So, sometimes people will come in and say, my thyroid's bothering me, and I say, that's not the right gland. So let's kind of orient us in terms of where the thyroid is. So the thyroid, let's see, I get this started here. This is a fancy new pointer that allows me to point, and it shows up there. So the thyroid sits at the base of the neck. It's a butterfly-shaped gland. It has a left lobe and a right lobe. Each lobe is about 2 inches long, about a ½ inch wide, and it has a huge impact on our bodies. So thyroxine is thyroid hormone, so that controls metabolism. Most people think of metabolism, they think of their weight, but this is more cellular function. So every cell in the body depends on normal thyroid hormone to do its job. And so that also then includes thermal regulation, heart function, nerve and brain function, muscle strength, GI motility, and fertility. So these are all very basic functions we take for granted. And if the thyroid's not working, if it's underactive, everything slows down. If it's overactive, everything speeds up. So certainly if the thyroid's not working, you are not working. So that's very important to have normal thyroid function in place. And as we talk about thyroid cancer treatment, sometimes we have to take the thyroid out and then do our best job replacing that function. So we're going to be focusing on nodules first. So nodules can be something that shows up as an asymmetry. This woman has an enlarged right side. If you look closely, you can see it's a little bit different from the left side, and that's what we call a palpable nodule. So sometimes a patient will feel a nodule, the physician or a dentist or someone else might feel a nodule. It's amazing, I'm seeing less and less patients come in saying that my doctor actually examines me anymore. They just type on the computer. And so less and less people are having their neck felt by their primary physician. But so this is what ends up happening most of the time is it's incidental thyroid nodule. This is a CT scan. So this dark space in the middle is the trachea. Next to this with a little calcified rim is a thyroid nodule. So when we think about patients that we see for thyroid nodules, this is a very common problem. So when the patient initially comes in with a nodule, they're worried that it's cancer, they're jumping to conclusions. So we kind of have to talk them down and remind them that the thyroid nodules are extremely common. It's almost an epidemic in that regard. If we did ultrasound on everybody in this room, probably half of people, or 60%, would have a small nodule or cyst, and that's fine. That's almost considered normal in large part as we age. By palpation, it's only about 5 or 10%. So certainly as we age, it's almost a per decade percentage probability of having a thyroid nodule, and that's why we see so many incidental nodules. So we looked at this 10 years, 12 years ago now. So we had almost 500 patients in 1 year referred to our office for thyroid nodule evaluation. So the question was, how was that nodule discovered, and does the discovery method have any impact on whether or not that nodule is a higher probability of cancer? So most of the patients were, so 40% were either 24 and 15 physical exam by a physician or a provider, and 15% were patient detected. The 60%, and this is still the case today, it's probably 60 to 70%, are incidental findings. So we all get imaging for a variety of reasons: carotid ultrasound to look at our arteries, CT scans for our chest. Now we use PET scans for cancer staging. So really, none of the tech methods of discovery impacted cancer rates that much, except for PET scan, which might make sense, and we'll talk about PET scan in a moment. So that was about 20% of our patients with a PET-detected nodule, and that means that it metabolized glucose more than a normal nodule would or a normal background would. They were more likely to be cancer, so that makes some sense, but otherwise there was really no statistically different. So often patients will have carotid artery ultrasound and they say, oh, the technician says I have a nodule. Sometimes it's so common that I know patients have nodules and they go for carotid artery ultrasounds and no one even mentions it, so the patient's almost disappointed. What if I didn't know I had this nodule and no one told me? But the reason we see them, of course, is the carotid is this very vascular round structure here. That's the carotid artery, and the neighbor of the carotid artery is the thyroid gland. So you see a vascular thyroid nodule right next to it, and here's the trachea next to that. So it makes sense that we see a lot of incidental nodules discovered in that way. So the PET scan, this is a very convenient radiology sign of avid glucose metabolism, so it lights up. So you see the trachea here, this is the spine back here, kind of reminding us that the spine sits right behind the trachea, and then the thyroid sits kind of overlapping the trachea, and that hot spot there is the thyroid nodule. So when I ultrasounded that patient, this little nodule of 1.5 centimeters, so just over a half inch, corresponded to this nodule on PET scan. So the old rule of thumb was about a 25 to 35% of PET positive nodules were cancer. In our experience, it's been a little bit less. In a recent meta-analysis, a meta-analysis means you take quality papers that have been published on this topic, and they found that about 15% to 20%. So that's kind of more in line with what we're thinking as well. But it's if we see these, we typically will biopsy them to try to figure out what's going on. So another common reason in PET scans is used very frequently for cancer staging, as many of you know. So my clinical questions typically are, is it cancer? But that's kind of, and that's none of it, that's a cheat. So now it's more of a, is it a clinically significant cancer? Because thyroid cancer is relatively common. Most of it's fairly indolent, and often we might even just watch it at some time. So if we see a 5 or 6 millimeter tiny nodule that looks suspicious, we might just watch that. And that's not something I'm as worried about necessarily. So I'm worried about, is this a cancer where if we don't intervene, there's a probability of harm for that patient, or is the patient very young? So if you leave it in for too long, you might end up with a problem down the road. So a lot goes into that. Is it a clinically significant risk for cancer that might harm the person? The second one is, does it cause symptoms? Most of these are asymptomatic, but some of the symptoms we see are related to the effect it has on neighboring structures. So you can have a choking sensation, cough, trouble swallowing, voice changes, or even cosmetic concerns. So we always ask those patients about that. Most of these are asymptomatic. And then, is it impacting thyroid function? So those are my 3 clinical questions. The patient kind of saying, well, why do I have them? They're not worried. They're saying, what can I change in my day-to-day life that, or what did I do to cause this nodule? And usually I can't answer that question for the individual patient. So this cartoon shows a person who is smoking a cigarette, eating fast food, this cell phone theoretical radiation, and concerned about radioactivity from Japan. So that cartoon, I'm not sure if it was meant to help me with this lecture or not, but it kind of brings up some of the risk factors that we talk about in terms of smoking, insulin resistance. So insulin resistance might come from a diet like this. The Western diet tends to foster insulin resistance and diabetes potentially. Radiation exposure, and the smoking, but also iodine deficiency. So if you look worldwide at the question of what's the most common cause of nodule or goiter, it's going to be iodine deficiency still, even though we've made advances in trying to replete iodine in certain areas that are mountainous, et cetera, that we still see endemic goiter. Autoimmune thyroid disease, so Hashimoto's, where the thyroid's attacked and the chronic destruction, that can create nodularity. And family history of nodules. There's also certain relatively uncommon genetic syndromes that are inherited that can cause a higher risk of nodules and potentially a higher risk of thyroid cancer as well. So kind of taking all of that in, but usually my answer to the patient is, there's really nothing you can do differently to change this trajectory of whatever your nodule is trying to do. So then we think about radiation. So previously the atomic bomb testing in 1950 to 62, that was a big concern because there was a lot of I-131 radiation exposure throughout the U.S., mostly in the areas highlighted, the dose exposure in the Midwest areas here in orange. But the half-life of I-131 would suggest that that's behind us now. So if we're seeing increasing thyroid cancer rates or incidence, it's not coming from prior atomic bomb radiation like we might have seen in the past. So now we have other theories about what it could be. So we do see different chemical compounds that can cause cancer, especially the bromated flame retardants is one, so the firefighters are at higher risk for all types of cancer, and we certainly see a higher rate of thyroid cancer in firefighters, but other things such as pesticides, plasticides, perchlorate, et cetera. So a whole list of things that are being looked at. So a lot of these are plausible, not proven yet, but we're trying to figure out why are we starting to see a slight uptake in more aggressive thyroid cancer. So we worry about these types of exposures. Now, this gets a lot of attention. We get asked every day, can I use these new medications for weight loss if I have a thyroid nodule? So this is like Ozempic and Mounjaro, et cetera, so semaglutide and tirzepatide. So these are glucagon-like peptide 1 receptor agonists, and they work very well for insulin resistance. They work very well for weight loss. And there's that black box warning saying patients with medullary thyroid cancer or that history shouldn't use it. But the Europeans have done some studies to suggest that diabetics who have been treated with these types of medications over time have a moderate relative risk for all types of thyroid cancer and a very small absolute risk. So currently in the US, our thought was there's no contraindication. If you have a thyroid nodule, we're going to monitor it anyway. So we haven't seen any proof that this is happening, but it's certainly on the radar. And every day patients are calling the office saying, can I start? Unless they have that history or risk for medullary thyroid cancer, the answer is yes, we're going to continue to monitor, and we don't know of a reason to say you can't start those medications at this point. So as we start the workup, clinical workup, the first question is, could this be a nodule that is increasing thyroid hormone production? So about 5% of nodules are autonomous. So autonomy means that the nodule doesn't pay attention to the usual feedback from the pituitary. So the pituitary communicates with the thyroid through a hormone called TSH, or thyroid stimulating hormone, and then that tells the thyroid to make more thyroid hormone. But some of these nodules have mutations in that TSH receptor, so the nodule will ignore the attempt to try to balance from the pituitary and produce thyroid hormone inappropriately. So those are autonomous nodules. It's easy to screen for that. We do a TSH blood test. If it's low, then remember it's feedback, so if the thyroid levels in the blood are going up, then the TSH is going to come down as a feedback from the pituitary. So if TSH is low, then that's suggesting of hyperthyroidism. That's the only time we do a nuclear scan in the evaluation of thyroid nodules, although we still see them over-ordered in the community, but that's the only time you need to do a nuclear scan for a workup of a thyroid nodule, is to ask that question, is this a functioning nodule? Is this a hot nodule or not? Because an untreated hot nodule or anything that causes excess thyroid hormone can lead to heart rhythm problems like atrial fibrillation, which could lead to stroke. Most of us probably know someone who have atrial fibrillation, or bone loss, so osteoporosis and a higher risk for fracture. So we certainly don't want to miss that. And the good thing about these nodules that are autonomous is they're almost never cancer. So once we prove that that's autonomous, we don't biopsy, but we treat it, either take it out surgically or give a small dose of radioactive iodine or other tricks to try to shrink and destroy that nodule. The issue is we're still doing too many biopsies. This is a slide I showed last time. There's not really a new study to say how many biopsies are we doing now, but I think so thyroid biopsies have probably now, unfortunately, gone from 500,000 a year to probably 600,000 a year, based on talking to some of the pathology labs and companies that have a vested interest in this space. So now we're doing 600,000 thyroid biopsies per year. They're easy to do, but I think if we really look at guidelines on pattern recognition that we'll talk about, this has been set up to try to decrease the number of biopsies that we do. And it all goes to ultrasound. So once you do your thyroid hormone assessment, and you say this is not an overactive nodule, then all of the decision making is based on what does that nodule look like under ultrasound. So this goes back to 2009, where different groups have tried to come up with patterns that are either benign looking or malignant looking or somewhere in the middle. So that's the idea of pattern recognition. So risk stratify based on appearance. The most common one that clinicians use would be American Thyroid Association. So this goes back to 2015. We're about to update it, but it's still trying to figure out which direction to go, so I can't have a slide yet on that for the new guidelines. But we have 5 different categories of risk, from benign looking like a benign cyst, all the way to high suspicion, emphasizing the importance of looking at lymph nodes. And then we have in the middle, we have very low risk nodules, and we have nodules that are intermediate or low suspicion. So this is, once you get used to it, it's pretty easy to look at a nodule and say, what's the risk of this being cancer based on ultrasound appearance? And what we look for is darkness of the nodule, that's hypoechoic. Microcalcifications are little punctate echogenic foci, infiltrative or invasive margins, taller than wide shape, extrathyroidal extension, or abnormal cervical lymph nodes. So this is what they look like under ultrasound interrogation. So you have the skin up here, carotid artery is here. This thyroid nodule is like a peanut standing up. So it's taller than it is wide. It's got little microcalcifications. It's got lobulations. So these are, and this is a nodule that's very typical for papillary thyroid cancer. So that's what that looks like. But one problem with these static images, and that's what the radiologists are often looking at, is the static images that the tech takes during the ultrasound study, is that some of these areas look like microcalcifications potentially, but if we look at these in real time, so this is how I would look at this in the office, we can see, once you get used to looking at them, that these little areas are little cystic areas that have little bright reflections behind the cystic space. So we call that posterior acoustic enhancement. So the point is not to teach you that, but to recognize the importance of expert thyroid ultrasound with real-time imaging as opposed to static images to make sure you don't classify something that should be low risk as high risk. So we see that frequently for patients being referred. This is another example of one of these nodules that has little bright reflectors due to cystic spaces in them. So you can see that obviously, but or easily in this, but during real time, but not necessarily during static imaging. One other issue is cystic nodules. So some nodules have a large fluid component and a small solid component. So the key part to interrogate is the solid component. So there's patterns of that we look for. So one that's higher risk would be when the solid component is at the side of the cyst. So this pattern bothers me a little bit, in contrast to this pattern where the solid component is kind of concentrically located around the cyst. So looking at these mixed solid cystic nodules, looking at the solid configuration, and then even worse is when you have a solid configuration that's at the edge of the nodule, edge of the cyst like this, that has microcalcifications and irregularity. So that's what cystic papillary thyroid cancer looks like. So some of these will have very obvious ultrasound appearances of either benign or cancer, but a lot of them end up in the middle. So then we have to decide which do we biopsy. So this is new as of 2017, and probably if you've had a thyroid ultrasound and you look at the report, you're going to see this type of nomenclature on the report. Just like if you look at a mammogram report, you'll see BIRADS. So BIRADS is a breast imaging reporting and data system, and they have categories just like we do for TIRADS. TIRAD is thyroid imaging reporting and data system, and that looks at individual features of, is it solid, is it cystic, is it dark or bright, does it have these little reflectors of microcalcification or not, are the margins irregular, is the shape taller than wide. So all of the risk factors we've talked about are incorporated, but they're assigned instead of a clinician saying generally this pattern looks one way or another, they're assigned points to try to make sure that every nodule can be categorized in one way or another. So based on the points then, we would decide on what to biopsy. So I'll show that in a minute. And of course, I can't present here without talking about AI. So AI is, it makes sense to use AI. We're talking about adding up points to categorize the risk of a nodule. So that's the kind of the statistical part of saying, what's that image look like? So the user, me, if I were using AI, which I don't yet, but I would put a little box in the area of interest. Then the computer algorithm would statistically say, that's a solid nodule, it's not cystic, so it gets 2 points for being solid, and it's the same echogenicity roughly as the surrounding thyroid, so it's isoechoic, so it gets 1 point. So that would call that a medium risk nodule. But you can, just like anything with AI, you can turn essentially the logic feature on. So they call this feature an automated assessment of a feature. So then the nodule, the algorithm would then look at other factors besides just the points and say, is this high risk or low risk? And in this case, it downgraded it to 2, which I look at it and say, that makes sense. That looks like a low risk nodule. So it probably shouldn't be a 3, it should be a 2. So we're going to see this evolve over time. So far, the studies looking at AI versus experienced users of sonography show that AI is almost as good as experienced users, which is pretty good. So, but the experienced users are a little bit better still, thankfully. So, but I think it's going to be nice from a community base to screen people a little bit differently so that we can maybe identify better which nodules are higher risk, ideally trying to minimize biopsies, but certainly not miss a nodule that's high risk that was thought to be low risk by a radiologist, for example. So once we risk stratify into one of these 5 categories, then there's size criteria for when to biopsy. So American Thyroid has size criteria biopsying high and medium risk above 1 centimeter, low above 1.5, and really we shouldn't biopsy very low, but we watch most of those. So that was one that we started using 6 or 8 years ago. And then TIRAD sort of shifted it a little bit. So the American College of Radiology lets things be a little bit bigger before we biopsy them, which I think makes a lot of sense. So as we're trying to minimize biopsies, obviously if we're biopsying things that are smaller, we're going to biopsy more nodules. So in this case, if we see these low-risk nodules, there's really almost, they suggest don't even follow up because they're so low risk of being cancer that we probably don't necessarily need to follow them. I tell patients that, and most of them say, I want to come back in a year or so and look at it again just to make sure. So we obviously, make suggestions, they make decisions, and we move through it that way. Once it's that low risk, it's 2.5, which is different than American Thyroid was 1.5. And then there's pretty much agreement on high risk at 1 centimeter and medium risk or moderately suspicious at 1.5. So often patients are saying, what are you talking about? So I picked up this from one of the National Institutes of Health saying, what is a centimeter? A centimeter is awfully small. I mean, it's less than ½ an inch. It's the size of a green pea here. So 2 centimeters is a peanut, 3 centimeters is a grape. So pretty much anything above this 2 to 3 centimeter range, depending on characteristics, we're going to consider biopsying it unless it is a simple cyst or a nodule that has that hyperplastic benign overgrowth appearance. And most thyroid nodules, will max out around this, 4 to 6 centimeters. So you have a lime, of course, and an egg and a walnut. So that sizes are helpful because most of what we're talking about is probably between a green pea and maybe a grape at best in most of our thyroid nodules. So we're talking about relatively small structures that we are considering biopsying based on their ultrasound appearance. So how is that done? So once we decide it's suspicious enough on ultrasound characteristics, it's big enough based on size, how do we do the biopsy? So the way we do it, we use a small needle, smaller than a blood draw needle, typically a 27 gauge needle, which is quite small. And it doesn't need lidocaine. We just use a little ice to kind of cool the skin off. And then we put the needle in under ultrasound guidance, and we can see this way the needle is along the line of the transducer of the ultrasound probe, or so along the face of it, so you can almost see the whole needle there. But then you have to use more needle to get into the nodule. So the way I do most of mine is putting the needle in perpendicular to the transducer so you can drop the needle directly into the nodule. So that's, you see the needle here, you see the carotid artery here, and again, the carotid artery is about 8 millimeters, so you're talking about something that's, that this nodule in this view is probably 7 or 8 millimeters, but in the other view it was maybe 12 millimeters, so this is what you're seeing. So it's a pretty small space, but the ultrasound guidance allows you to very confidently get the needle into the right place and avoid things like the carotid artery. So then what happens? What does that look like? So then we look at it under the microscope while the patient's still there to mainly say, did I get enough? Because I don't want to have to bring the patient back in 2 weeks when the pathologist said that was mostly blood, there wasn't enough thyroid cells. So we take a look at it, and when we look at it, we stain it with what we call a diff-quick stain, right Giemsa stain, and that's what it looks like in our lab. Then the more complicated stains, Papanicolau stains, take an hour or so, and that our pathologist will do this stain as well, and that helps kind of bring out the nuclear features of the cell. So the combination of these two stains helps the pathologist categorize the nodule diagnostically into yet another category. So we go from ultrasound category, then we're going to go to cytology category. So the current the system that we use is the Bethesda system for thyroid cytopathology. It was updated in 2023, and what it's trying to do, based on these six different categories, is kind of guide us clinically on what do we do next now that we've committed to the biopsy. The most frustrating is the non-diagnostic, which is why we look at the slides for our patients while they're still there, because they still have a 13% risk of cancer, a mean risk of cancer, so we repeat those biopsies. Then straightforward benign is only about a 4% risk of cancer. So if you have a asymptomatic nodule that's benign by cytology, then we periodically would follow that for a certain number of years and then offer the patient to graduate from surveillance if he or she wants to graduate. Often they keep coming, which is fine. Then you have suspicious for malignancy or malignancy. So those are high risk, and historically we've taken those patients right to surgery because the risk of malignancy, if it looks like cancer, it's 97%. And clinically, you always want to tell the patient it's not 100%, it's 97, 98, 99%, because there's going to be a few patients who go to surgery and have a benign nodule. And certain benign tumors will look like cancer under the microscope when you do the biopsy. So it's very important to make sure you explain to the patient that there's a very high probability of cancer. You might be lucky that it's not, but don't go to the casino, go to surgery, because it's only about a 1 to 3% chance that it's not cancer. Then in the middle here, we have all this atypical of undetermined significance and follicular neoplasm. So this is classically what we call an indeterminate cytology. So we know what benign looks like, we know what high risk for cancer looks like. Now we have something in the middle that's indeterminate that has about a 22 to 30% chance of cancer based on cytology alone. So that's kind of our dilemma of what do we do with these patients. They end up being about 15 to 20% of all the nodules that are biopsied. And if we're biopsying 500,000 nodules per year, you're talking about 100,000 patients in the US alone who have an indeterminate nodule. So before 2013, we would send everyone for diagnostic surgery. But remember, the rate of cancer in those patients was about 20 to 30%, which means 70 to 80% of patients had a benign outcome, which they're happy about, but they had to go through a surgery to figure that out. So this is, that was kind of an issue of unnecessary surgery that was diagnostic. So molecular testing has evolved significantly. I've been involved in this for 15 years from the start of the studies of it, then commercially available in 2010, 11, 12, depending on what your access was. But now there's 3 commercially available tests for patients who have an indeterminate thyroid nodule and you're not, and they don't have an other indication for surgery. If they already have an indication for surgery, you can stop and say, let's go to surgery. We don't need to spend money on molecular testing. But if you have a young patient who's trying to avoid surgery, or an older patient with other medical issues who has still a good life expectancy ahead of them, and if you can avoid surgery and avoid harm, then that would be obviously welcome. Then that's where we use these tests. So they're based on either RNA, or DNA or both, and then also microRNA. So that's the different algorithms. It looks at DNA mutations, RNA fusions. It looks at messenger RNA, different gene expression classifiers. So there's a whole kind of machine learning that's gone on to try to classify these. And I think one of the best part about it is if these tests say this is a benign looking nodule, it's probably 94+% probability of benign, which is very similar to a benign biopsy. So now we call that molecular benign, and the other one was cytology benign, and we can follow those safely over time. And most follow-up studies over now, we have 5 to 8 years of follow-up for these nodules. Most of those nodules don't grow or change. So I think that's been a true benign. So we're very comfortable with that. The positive predictive value can be anywhere from 30 to 99%, depending on what we find. So we still need to tease out a little bit more on the positive predictive value. But most of the ones that are positive, probably we would go for surgery because of the risk for cancer. But that takes out about 2/3 of patients who we used to send for diagnostic surgery. The benign call rate's about 60 to 65%. So if you can take those people out of the surgery queue, that's a huge benefit to patients. But always combine all of the clinical information as you're making these decisions. So indications for surgery in general would be if we're concerned about a potential clinically significant cancer, it would be an option for one of those autonomous or overproducing nodules, or symptoms due to size. So trouble swallowing, cough, voice changes, breathing difficulties, cosmetic concerns. Sometimes you walk in the room and the nodule is almost the first thing you see as you're getting to know the patient. So that can be an issue as well. But there's also non-surgical options, and this list keeps growing. So for benign symptomatic nodules that are increasing in size, sometimes patients are hypothyroid, they didn't even know it. So patients with Hashimoto's who are autoimmune hypothyroid, if they're not treated, their thyroid stimulating hormone from the pituitary is high. So that thyroid stimulating hormone makes the nodules grow. So if you correct that, then the nodules will shrink. So always make sure you're not dealing with an untreated hypothyroid that's correctable. If they're iodine deficient, which is relatively hard to find in the US, then we would replete that. Sometimes the nodules will take up radioactive iodine, so we can leverage that uptake of radioactive iodine to deliver radiation to shrink them. If it's a cystic nodule, you can drain it and put alcohol into it, and that causes some fibrosis and scarring, so it kind of sticks together so it doesn't reaccumulate. Then there's thermal ablation, so radiofrequency, which a lot of people have heard about for atrial fibrillation ablations or other. We use it for back procedures as well. And then high frequency ultrasound, which we're not yet doing in the US. Laser therapy, so laser would also deliver heat. And then we just started last year doing embolization. So patients who have large goiters that are extending into the chest, who might be poor surgical candidates, because that would involve opening the chest, that interventional radiologists will actually embolize or knock out the inferior thyroid artery, and that kills off, essentially, purposely, the thyroid. So it'll shrink that up very nicely. So that's something that has to be done in a well-controlled setting, because it obviously would cause thyroid function abnormalities. So we have a protocol on how we do that with interventional radiology. But it's nice to have a menu like this compared to when I was here 7 years ago, where I think we talked about these things might be coming, but now we're using them on a regular basis. So kind of briefly, what does radiofrequency look like? So this is an outpatient clinic-based procedure. So the operator would set at the head of the patient. You have the electrode, which is the needle, essentially. It's a 7 centimeter needle. It's 18 gauge. So anyone who knows, 18 gauge is a fairly big needle. And then you have grounding pads, because it's a radiofrequency generator, and a cooling water pump, because you want to cool things in the neck on the electrode. You want to heat only what you need to heat, but everything else needs to be kept cool. Otherwise, you can cause a lot of burning in that regard. So this is what it looks like when we're doing it. You put the needle in. So again, this is the thyroid. This is the trachea. So you put the needle in and then move it. It's called a moving shot. So you put it in and you pull back, you relocate it, and you pull back, then you relocate it, then you pull back. So it's a very user-dependent technology, right? This isn't just stick something in and the computer will figure it out. There's a lot of movement, and it can be very tedious. It can sometimes be a 30 to 45-minute session. But it's an option it's a non-surgical option that is gaining traction in the U.S. over the last 2 years. Laser is similar, maybe arguably more elegant, but in some studies not as effective. So laser places 1 to 3 optical fibers in that same kind of approach this way into the targeted area, and then you leave them in one place. So you're not moving them, you're leaving them in one place, and then the algorithm would deliver energy kind of in advance of the needle, so in front of the needle. So this is the energy delivery in front of these optical fibers that are in the target nodule. So the bigger the nodule, the more fibers you place to try to cover it. So that's another option as well, and we're able to offer that, luckily, locally in our area, and many other areas are starting to as well. So we've kind of talked about thyroid nodules and kind of the benign track, and what options we have for benign, both surgically and non-surgically, and that many nodules can just be followed without any treatment whatsoever. But let's talk about the thyroid cancer types. So we divide this up to differentiated thyroid cancer, so thyroid cancer that comes from normal thyroid follicular cells. Those are differentiated. So 84% of all thyroid cancer patients are going to be papillary thyroid cancer, and about 5% of those have an aggressive subtype. And usually it's a tall cell papillary thyroid cancer that's your more aggressive subtype. So when we talk about thyroid cancer in general, most of the time we're talking about papillary thyroid cancer. So follicular thyroid cancers are about 4%, oncocytic 2%. Oncocytic we used to call Hürthle cell cancer. So if you have been following thyroid nodules, it used to be Hürthle. But we realized they're genetically distinct from follicular. We thought it was a subtype of follicular, but they have different genetics to them now that we're getting better at picking out on these molecular tests that we've talked about. Poorly differentiated means it started off differentiated, then it got less and less organized over time. So if we think clinically about this, differentiated behaves more like normal thyroid. Normal thyroid takes up iodine to make thyroid hormone. So we would often use that for radioactive iodine treatment. Normal thyroid makes thyroglobulin, which is where we store thyroid hormone, and we use thyroglobulin as our cancer marker. As these get poorly differentiated, they don't take up iodine, they don't make thyroglobulin, they behave more like adenocarcinomas that you might see in the lung or colon, and so it's kind of a different paradigm. Anaplastic, fortunately, is 1% or less of our thyroid cancer. But at 1%, it accounts for about 20% of the annual thyroid cancer-related mortality each year. So this is the most aggressive cancers that humans can get. The median survival is 6.5 months with anaplastic thyroid cancer. So there have been some breakthroughs on doing genetic testing right up front and trying to use chemotherapy, some sort of therapies before surgery if it hasn't spread. So we're making some progress here, but in one gland, you have potentially, arguably, one of the cancers, papillary, that has some of the best prognosis that human cancers, and same gland has anaplastic, which has the worst prognosis for human cancers. Then you have the medullary thyroid cancer. So medullary comes from the C cells or the parafollicular cells. We talked about medullary briefly when we were talking about semaglutide and tirzepatide, which are the weight loss medications that has a black box warning, say don't use these if you have a risk or have medullary thyroid cancer. It's about 4% of thyroid cancer. It's 25% of it is a RET germline mutation. So if you have a patient with medullary, you want to test that patient to see if family members could be impacted. So most thyroid cancer is not symptomatic. You would think if I had cancer in my thyroid, I would feel something different. So only probably 30% of patients have either neck mass that they feel, dysphagia, a globus, or like a foreign body sensation, or hoarseness. And it makes sense that if you have those symptoms, probably that's a larger or a more aggressive cancer. But most of them are asymptomatic. And patients are surprised they could have a cancer and not know it. So what's the current data? So this is the SEER data that keeps track of estimates of cases per year. So now we're looking at 2024, estimated 44,000 new cases, which is about 2.2%. So thyroid cancer is about 2.2% of all new cancer diagnoses. Estimated death is about 2170, and about 0.4% of all cancer deaths. 5-year survival, 98.4%. That's excellent. So some people, it's so good. Some people have been bold enough to call it a good cancer. Never, no such thing as a good cancer. You always want someone else to have that, not you. But it does generally, it's reassuring that there's a 98.4% 5-year survival, last calculated up to 2020. And this curve is important. So this is the incidence, the rate per 100,000 persons per year. So this really shot up between late 90s and about 2010 to 2012, and that's when we started seeing more incidental nodules. We started using more ultrasound, arguably too much office-based ultrasound even, finding small nodules. We didn't have guidelines to say, don't biopsy that 8-millimeter nodule. So this shot up dramatically, but the mortality has been relatively flat over the last 30 years, right around 1,900 to 2,200 per year. So often, my wife always says, if I come home and say, I saw a patient with, she says, how old? Well, male or female? What is it? In other words, am I at risk for this? So the median age at diagnosis is 51, and you'll see that most of the patients are being diagnosed between 35 to 74. So you see a whole split here, but around 50 is your typical age of diagnosis of thyroid cancer. The staging used to be, if you were younger than 45, you could either be stage 1 or stage 2. We realized that these patients were doing so well that we shifted that to 55. So that means that if you're 55 or younger, or less than 55, even if you have a metastatic thyroid cancer, you're only stage 2. So the staging is really related to survival in that regard. So even young patients with more advanced disease do well, and 55 is that cutoff. Once you're over 55, then your staging can go up to stage 4. So looking at how these patients come to us newly diagnosed and what stage or what level of involvement are we seeing, so this might be somewhat hard to see, but localized means that it's confined to the thyroid itself. So that's 2/3 of our patients, 64%. They have a 99.9% 5-year survival. So if you have a cancer that's confined to the thyroid, you're going to do very well, which will lead to other questions of how much treatment do we really need for some of these patients. Regional, so 30%. So often we think lymph node involvement is automatically really bad. So even with lymph node involvement, there's still a 98.2% 5-year survival. So patients are still doing well. And I think what we have to always tease out, and even I get questions via email from other endocrinologists saying, this person had 2 lymph nodes involved and there were 3 millimeters of involvement. And I say that tumor biology is very indolent. That's not going to do anything. If you have more than 5 lymph nodes involved, or if you have a lymph node that's more than 3 centimeters in size, then that's where you begin to see tumor biology that's capable of more extensive lymph node metastasis and spread. So you always want to, you can't just say regional lymph nodes yes or no. You've really got to be granular about the involvement and then risk stratify that better. But if the patient has metastasis, which only about 3% of patients present with metastasis, things change. The 5-year survival now is 51.9%. And if we don't know, it's 92.7%. So most patients have disease that's confined to the neck with or without lymph node involvement, and they do very well. As we stratify risk, this gets a little complicated, but this is based on the American Thyroid Association clinicians' kind of guide to, once you've done surgery, what's the risk of structural recurrence? In other words, what's the risk that something's going to come back somewhere or a new metastatic site that we're going to have to deal with? So this originally was based on the types of cancer, lymph node size, extrathyroidal extension, how invasive it was into blood vessels, things like that. But now we're adding these molecular components. So we have been using molecular for diagnostic to say if I have an indeterminate nodule, is it likely cancer or not? Now we're using molecular to say what's its likely behavior. So if you have these RAS-like mutations that are relatively weak driver mutations, then they're lower risk. If you have BRAF, that's higher risk. If you start combining multiple mutations, then you have very high risk. So now we're learning prognostics from our genetic signature. We're not yet doing genetic testing on everybody with thyroid cancer for this, but I think if it becomes cost effective, it might be a reasonable thing to do. So what does this look like clinically? So you have the BRAF-like, which is typical papillary thyroid cancer, tends to look like these darker nodules with the microcalcifications, like this one. They tend to be on cytology more likely cancer, and they tend not to take up the radioactive iodine as well. RAS-like are more follicular, they spread by blood, and they respond to radioactive iodine better, and they tend to be indeterminate on cytology. So that's how we think through this. But the RAS mutations, remember I said if you had a molecular test that was positive, there was that risk of cancers down to between 30% and 99%. So most of that 30 to 50% is driven by these RAS mutations. And half of them are benign adenomas. About a quarter are cancers, usually low-grade cancers, and about 25% are NIFT-TP, which is a non-invasive follicular thyroid neoplasm with papillary-like nuclear features. That came into the play about 8 years ago, taking some patients with low-grade cancer and saying they're not cancers. These are pre-cancers. They still need to be removed, but we really need to do more work to figure out if we can risk stratify those better. So as we think about surgery for thyroid cancer, there's a choice between total thyroid removal and lobectomy. In general, if you don't have lymph node involvement, you don't have bilateral cancer, you don't have high-risk ultrasound features like extension beyond the thyroid, if it's less than 4 centimeters, you can just take out that lobe, and those patients should do well. If it's more than 4 centimeters, then the American Thyroid Association is still suggesting total thyroidectomy. So last year, there was a very large study that was published kind of addressing this question of survival in patients with papillary thyroid cancer stratified by lobectomy versus total thyroidectomy. So 84,000 patients in the database, so about 23,000 had lobectomy, the rest, 62,000 almost, had total thyroidectomy. There was no difference in 10-year survival between the two groups. And they looked and said, well, what if the tumor was bigger? There was no difference if it was more or less than 4 centimeters. Well, what about older patients? We think older patients don't do as well. There was no difference age less than 65 or more than 65. So this is offering kind of a new thought about more confidence to us about doing lobectomy for patients even at 4.5, 5 centimeters, depending on the individual situation. Still, our algorithm looks like this. This is based on current guidelines, and this might evolve more over time, where the 4 centimeter one, less than 4 centimeters gets lobectomy, and higher and intermediate risk, and more than 4 centimeters, total thyroidectomy. But this is where we go back to ultrasound and say, before I do thyroid surgery, this is a nice cartoon from the Thyroid and Head and Neck Cancer Foundation in New York. And this is one diagram that they've used, and I helped with this years ago, to say, how do we map this out, right? So here's the thyroid, and unfortunately, a lot of the preoperative imaging stops at the thyroid. It stops right here. And if you don't look out in the lateral neck here, we call this lateral neck because it's lateral to the carotid, that's the left, that's the right, you miss the lymph nodes. You've got to look to make sure there's no lymph nodes because that'll define extent of surgery and will tell the surgeon we need to take out these lymph nodes because we don't want to find out about them 2 years later and say, oh, you recurred because we never looked, it was always there. And that's usually, the recurrence is not a recurrence, it's a we didn't look well enough. So this is a right lymph node that's partially cystic that's behind the jugular vein here. This is a left lymph node that has those little calcifications. But if you stop your study at the thyroid, you never see these. So always important to make sure that the lymph nodes are assessed. Then we want to choose a surgeon who has good surgery experience because there's complications. We have voice changes, vocal cord paralysis potentially, which is a permanent voice change. We have parathyroid glands that control calcium. If they get sacrificed, then we have low calcium. Of course, there can be hematoma or blood collection, swelling, scar. And now we do have transoral surgery. So if someone says, I'm really worried about a scar, they can actually go through the mouth and do simple thyroid surgeries that way for lower risk cancers. Not many places are doing that, but we have that available in Sarasota now, which has been great for patients especially young patients who want to avoid the scar. And anesthesia exposure, especially as we get older, we don't want to have a lot of anesthesia exposure for cognitive function issues. So it makes sense that the thyroid surgery volume, in other words, how many surgeries do you do per year, would be related to your risk of complications. So this study of 72,000 patients, a big database again, defined a high volume surgeon as more than 50 per year. So on average doing 1 a week or more. Medical complications, odds ratio was, it's 57%. So it was instead of, it's a 43% lower risk essentially than if you did fewer surgeries. Surgical complication odd ratio is 0.67, and death or life-threatening was 0.21. So fairly significant reduction in odds ratio if you have a surgeon who does more. Unfortunately, we still see a lot of the thyroid surgery in the US done by surgeons who are probably doing less than 10 per year. So our complication rate's higher. So the point is you have time to carefully assess. If you're told you need thyroid surgery for suspected or diagnosed cancer, most of this is going to be pretty stable for several months. So you have time to figure out how much surgery do I need, and you have time to find a surgeon who has the kind of experience to minimize the complications. So then we go back to this chart and we say, you've got an increase in diagnoses or incidence with relatively no change in mortality. That brings up the question of, are we overdiagnosing thyroid cancer? Is there a role for active surveillance? So just one slide on that. Now we're seeing mounting evidence that looks just like what Ito and colleagues in Japan that showed us 15, 20 years ago, that if you watch these patients for 10 plus years, about 10 to 15% will have a volume increase in tumor size. The younger you are, the more likely you are to progress, which makes some sense. Only 1 to 2% will have a clinically abnormal lymph node that shows up during follow-up. And if you've delayed therapy and say, okay, now I meet these criteria for doing something, the outcome is the same as if you had done something in the beginning. So, so active surveillance is for the right patient who doesn't want surgery, et cetera, might be a reasonable choice, but it takes a careful team to get that right. So once we've done surgery, then we think, what's our risk stratification? So I keep talking about all these risk stratifications, but at each step, we have to re-stratify the risk of patient having structural recurrence, and depending on that risk for recurrence, what else do I have to do for them? So the low-risk patients, which are about 54% of all the thyroid cancer patients, they can have lobectomy, thyroid, or total thyroidectomy. They have a less than 5% chance of recurrence. You don't need radioactive iodine. And the other question is, remember TSH is thyroid stimulating hormone, and we can use thyroid medication to bring that down. We call that suppression. So we don't suppress those patients as much, because if we over-suppress, we talked about too much thyroid hormone causing heart rhythm problems and bone loss, so we always want to mitigate that. So we keep the TSH lowish for those patients. The opposite would be the high risk, so 8% of all cancers. They have a 30 to 55% of risk of recurrence. So this is a high-risk group. Almost all of them will get radioactive iodine, and they will get TSH suppression if they can tolerate it. So you want that TSH to be as low as possible so you don't stimulate. It's kind of almost like weed killer for the garden, so you don't stimulate growth there. The middle group is about a third of the patients, 10 to 20% risk of recurrence. Selectively, they get radioactive iodine, and then their TSH is a little bit suppressed. So this was a very nice table done by a recent cancer summary by the MD Anderson group that kind of helps kind of put this clinically right into perspective of how we think about it. After initial treatment, we use thyroglobulin. Remember, thyroglobulin is the protein that is produced and helps store thyroid hormone. So differentiated thyroid cancers make thyroglobulin, so it's very reliable. Neck ultrasound, because if we have recurrence, it's usually going to be in the neck. Monitor TSH. What if a patient had a lobectomy? We don't automatically put patients who just have half their thyroid out on thyroid hormone, but we realize if patients have had half their thyroid out, a recent study showed about 29% will need thyroid hormone at some point. So we want to follow that TSH. That's what we've seen in our office too. About 25 to 30% will need thyroid hormone at some point. We use ultrasound to follow them. But sometimes these things aren't making sense. You see a thyroglobulin go up. I don't see anything on neck ultrasound. So then I have to use CT scan of the neck, of the chest, PET scan, and sometimes iodine whole body scans to figure out what's going on. But sometimes it does advance. So the last few slides are on these few cases, probably less than 3 to 5% of what most of us would see in our thyroid cancer clinics they have metastatic disease. So this is it's kind of a funny, it's a picture that shows radioactive iodine uptake. So this is like this is the silhouette of a person, the head's up here. You see a little bit of bowel and bladder activity, which is physiologic, but you see all these lung mets here. In some studies, about half to two-thirds of patients, even if they have mets, will take up radioactive iodine, which is great, because if your metastasis takes up radioactive iodine, your 10-year survival is about 50 to 60%. If your MET does not take up radioactive iodine, your 10-year survival is 10%. So you really want your disease to take up radioactive iodine. We know that it's about these BRAF V600E mutations, which is about 60% of papillary, don't accumulate radioactive iodine as well. So we'll kind of save that thought of what can we do to restore that for a few slides from now. So what do lung mets look like on PET scans? So this is a fairly obvious PET positive lung met, and what we found is that if they're PET positive, that means they're really glucose metabolically active, they're much less likely to take up radioactive iodine. So there's an inverse relationship between PET activity and radioactive iodine avidity. So this really, when we get these patients that are this complicated, I mean, always the patient's at the center of it. We always try to function as a team. What I see in the community, though, even for low-risk thyroid cancer, often people are taking care of these patients. It could be an endocrinologist, could be an ENT, it could be a general surgeon. Sometimes a radiation oncologist gets involved and they get radioactive iodine even though they probably didn't need it. And we still see that happening for lower volume centers that aren't seeing enough of these patients to present them as a team to say, what extent of surgery do we need? Do we need radioactive iodine? And most of these patients, less is more in general for most patients. But making sure your team is in place and the expertise is there is important, especially when we talk about these patients who have distant metastasis that aren't taking up radioactive iodine. Now we need to really figure out what can we do with them. So that's where the medical oncologist almost never see a thyroid cancer patient, and the endocrinologist almost never see an advanced thyroid cancer patient. So there's this kind of gap between specialties in terms of really nuancing the care for some of these patients. So this was a wonderful kind of construct by Maria Cabanillas from MD Anderson, and this kind of takes us through the whole journey we've been talking about. At the base, you have surgery, and you might suppress with TSH. You might give, and then you give radioactive iodine if it works, and then we watch to see, does something progress? Are symptoms coming up? If something is a local, like I had a patient last week who had a new metastasis in his humerus, in his arm, right? So we can treat that with surgery and external radiation and not think about other therapies. But if you have patients and then we can use bone stabilizing medications. These are patients who are very rare in the thyroid cancer realm. But the whole idea here, before we get to kinase therapy, which is an oral medication that targets tyrosine kinases, different types of targets for cancer development and for blood flow, we want to exhaust everything locally. So everything we can do to try to stabilize before we commit. Because once we commit to systemic therapy with these pills that are what we call kinase therapies, these are patients that they stay on that therapy until it's not working, or they go from one therapy to the next. So before we start, we have to make sure we don't have any other options and that they're clearly progressing and that they might become symptomatic. But fortunately, that landscape has changed. This slide looks very busy, but to a clinician who sees advanced thyroid cancer patients, it's wonderful. That means we have options. 7 years ago, maybe half of these targets were on here. Right now, we have more targets. And I'm going to highlight just probably 4 of them. So over here, we have the vascular endothelial cell. So the blood vessels. So tumors don't survive well if you cut off their blood flow. So a lot of these therapies are going to be anti-angiogenic to cut off blood flow. Then you've got different receptors, different fusions and mutations like RET and NTRK that you have now targeted therapies, not just for thyroid cancer, but any cancer type. So the more targeted your therapy is, the higher the efficacy and the lower the side effect rate. So that's been very new in the last couple of years. Immunotherapy gets talked about quite a bit. So now we're using immunotherapy for advanced thyroid cancer, especially poorly differentiated and anaplastic thyroid cancer. And we talked about the I-131. So we know if I-131 works, those patients do better. So there are now therapies, kinase therapies, that can restore I-131 avidity. So now patients who were thought to be non-avid have a chance of responding to radioactive iodine for metastatic disease. So this is really, for us, it looks like a busy slide, but it's a very encouraging to see so much progress in the last 7 years in this field. So in summary, we know thyroid nodules are very common. Most, probably only about a third of the ones we see in the office who get referred need biopsy after a good skilled examination. About 5 to 10% end up being cancer. Most of those do very well, but need to be managed properly. So let the punishment fit the crime, essentially. So limit the extent of surgery, maybe offer active surveillance. Eventually, we might do thermal radiofrequency ablation for small cancers. And advanced thyroid cancer rates appear to be increasing, but luckily we have new targeted treatments that are coming out each year to have things to offer and hopefully improve our survival and outcomes. So I know that was a lot of information, and thank you very much. I'm here for questions. So I think we have a roaming microphone coming. Yes.
Some questions. Okay. Wait, I see you back. Okay. Here you go, ma'am.
That's a neat microphone.
Yeah. What would be the drug that you would use in infusion during that period of time after surgery? Do you have a set of drugs that are used like they do for pancreatitis and
or for pancreatic cancer?
pancreatic cancer, definitely.
Right, so the traditional chemotherapies or cytotoxic chemotherapies really don't play a role for thyroid cancer. They don't work very well.
Oh.
So most of these treatments that the advancements we've been seeing are going to be oral capsules of these tyrosine kinase inhibitors. And even the immunotherapy could be infusions or tablets. So most of our thyroid cancer patients don't ever need any of this. If we estimate how many advanced thyroid cancer patients there are out there, it's probably 4 or 5 persons per million persons per year. So that's a lot. That's why we want to go to specialized centers when we have patients who have advanced thyroid cancer. So there's no routine infusions that we would use after surgery for 98% of our patients.
But there would be some.
There could be some, yes.
Okay.
Yes.
I'll be back. Here you go, ma'am. Can you catch it?
Do you find that people with nodules usually originally have either Hashimoto's or is it Graves' disease? Which is more prevalent where cancers are found?
Probably Hashimoto's for a couple of reasons. One, Hashimoto's is more common than Graves' disease. 2, Hashimoto's will cause a chronic inflammation that doesn't go away. So chronic inflammation lends itself to nodules and to metaplasia, which could cause cancer as well. There's a slight increased risk of papillary thyroid cancer in Hashimoto's. Graves' disease tends to cause some inflammation, but depending on how we treat it, it usually is transient. So we don't see as much cancer in that regard, with the caveat that Graves' disease is driven by TSH receptor antibodies that are stimulating. So if you have a cancer that's thyroid cancer, you don't want extra stimulation to that cancer. So I screen all of my Graves patients with ultrasound to see if there's a clinically significant nodule that needs to be dealt with. And it helps me try to figure out their Graves treatment options as well. So good question.
Thank you.
Okay, I'm going to toss this to you. You got it?
So I found out I had a thyroid nodule after spending a night in the hospital after a seizure, epileptic seizure. And the hospitalist told me that I should have tell my doctor about it. And that's all he said.
Okay.
And is there a relationship between the epilepsy perhaps and...
Not that we know of between epilepsy and the nodule. I think that's a classic situation of an incidental nodule. So when they were working you up, maybe looking at the carotid artery or doing brain imaging or vascular imaging, they found an incidental nodule. So, not related to your episode. So those are ones that we would then look at thyroid function, TSH, for example, because thyroid hormone abnormalities lower seizure thresholds. The nodule doesn't change it, but if the nodule is an overactive nodule, that hyperthyroidism could lower a seizure threshold, just like hypothyroid could. But most of them are going to be normal, thyroid function. Then you do ultrasound, and then you use that risk stratification to say, do we need to biopsy this or not? So that's the usual approach to that situation.
And what kind of place do I go to tell my doctor I need to?
Right, so usually an endocrinologist would be someone who would handle it. Sometimes it's a surgeon who does a lot of thyroid work could do it, but in reality it ends up being a community-based radiologist doing an ultrasound and then giving that report that reports that TIRAD system, and then your ordering doctor would look at it and see if they suggest a biopsy. Then you would go back to a radiologist for a biopsy. My pet, to me, it's a lot of trips. I'd rather, see, if I saw you, I could tell you at the same time, you need a biopsy, and just do the biopsy that day. So that's how we like to do it, but there's not a lot of people who do it that way. I'm not up here, no.
Lovely place to spend the weekend.
That's true. That's
There
true.
you go. I got you guys.
I wanted to ask, is AI that you were talking about, is that using the standing images, or is it using the real-time image sets?
It's sitting working right.
Right. So the question is, what's the algorithm for the AI? So they're trying to use dynamic imaging, where you would scan the whole thyroid and then let the system pick the best images. That's evolving, but they were initially based on static images, or standing images, as you call them.
Because I remember that you said that radiologists normally make mistakes with just the standing images and classify them as higher degrees than they really are.
This is a great point, because what at least the Mayo Clinic AI folks are trying to do is put the whole cine loop into it, so that they can use all of the information. The one I showed you an example of, one concern I have is it's based on a static imaging, and then the user putting a box on a static image and forcing the AI to make decisions off that, which I think might be limited.
Do you think as time goes on, it could be better than that, where AI can enhance the image and also let us see it with just a standing?
Yeah, I think what we'll probably end up, in an ideal world, we would have a protocol where you say, okay, now scan through the left lobe, and then the AI could look at all of those images, which will be thousands of images, essentially, and then make decisions based on that. I think that's going to be the better version of AI. But that's a great distinction. Thank you.
After a full thyroidectomy, how often do you have to sacrifice the parathyroid glands, and how does that affect the clinical management afterwards?
Yes, so to me, managing a complete loss of parathyroid function is much harder than managing loss of thyroid function, because of the calcium balance issue. A high volume surgeon, this is where you go back to the high volume surgeons, they might have that 1% to 4% risk of post-surgical complete hypoparathyroidism, but that might go higher if you have a very invasive cancer, so your oncologic intent on that surgery is, you're often sacrificing parathyroid glands. There's newer technology based on autofluorescence, where the surgeon can identify the parathyroid glands better and then maybe auto-transplant them. It doesn't work all the time, but they can take part of the parathyroid gland and transplant it into the sternocleidomastoid muscle, for example, and then often that'll take and at least give a source of parathyroid hormone. Doesn't always work, but there are some tricks if you know you have a very advanced cancer situation to try to save some of those parathyroids before you start the cancer surgery. So it's hard to treat, because the hypocalcemia, that's certainly, talking about seizure thresholds and things like that, low calcium is very difficult for patients' quality of life. And we used to have subcutaneous PTH, or parathyroid hormone, to give these patients, and that got taken off the market. So we're hoping that another company will bring that back, because I have a handful of patients who, despite prescription vitamin D and calcium, their kidney function suffers because of calcium issues. They have kidney, calcinosis. They end up with a lot of issues, quality of life issues. So that's a great question.
Another quick question. In a screening for hypothyroidism, I mean, a patient with weakness, fatigue, tiresome, whatever symptoms you're thinking of, is it adequate just to get a TSH, or should you get a T3 and T4 as well? If I'm taking a board exam, the answer is TSH, because that's going to pick up 99%. Right, so TSH, and there is a TSH with reflex to T4. So if the TSH is high or low, they'll do a T4 for you. So I think that would be, from a screening standpoint, TSH is the most appropriate.
We have one more here.
Yes.
MTHFR genetic defect. How does that relate to thyroid issues?
Yeah, I think we're learning that. I think that's something that I think there probably are some issues, but I don't think we have a good consensus on how we need to modify therapy yet for those patients with that mutation. But I appreciate that question.
All right, everyone. Please give Mark a thank you.